Welcome to Baby Snugs and Coffee Mugs. I'm Krista.
And I'm Kelsey. We're both labor and delivery nurses from Minnesota. In this podcast, we'll be covering all things pregnancy, delivering in a hospital, and caring for yourself and baby postpartum.
This podcast is meant for educational and entertainment purposes only, so please seek medical advice from your healthcare provider. We are so excited for you to join us, so grab your coffee, snuggle up, and keep on listening.
Cheers!
Cheers! Welcome back, everybody, to episode 12 of Snugs and Mugs.
Welcome! This week, we are going to be following up with last week's episode, which was a scheduled C-section. We ended with the PACU nurse leaving that room. So we're going to continue this week with kind of an overview of everything. There's a lot to talk about, so we're going to try to just break this up into little sections to hopefully make it easier to listen to and understand. As always, if you have questions, just send them our way and we'll touch base on them. But anyways, the PACU nurse is leaving. Your OB nurse, your primary nurse, has probably been with you the entire time, unless shift change is going to continue to be with you. So if you think you were no longer going to look at our faces, that is not true.
We're still here.
Still stuck with us. So anyways, right away, we're going to do an overview assessment of you. Mm-hmm. Vital signs, of course, right away, making sure that those are all within normal limits. Then we're going to be checking your belly. We are going to be doing fundal checks on you. We are making sure that your uterus stays firm. So after a C-section, there is a chance that you can still have what we call a postpartum hemorrhage, and that is where you bleed a lot. Your uterus stays strong and contracted to prevent that bleeding. So when we're pushing on that belly, we're trying to make sure that it's staying firm, and if it's not, we're going to massage it a little bit to get that to firm up as well. Yep. Coinciding with the fundal check, we're actually going to be looking at your bleeding too. You still bleed after a C-section. I think a lot of people think that that doesn't happen, but you can still bleed up to 6 weeks after. It's definitely not as much as if somebody's had a vaginal delivery, if you've talked to a friend or family member, but it still is happening. Yes. You're still bleeding.
So guys, your placenta is detaching from your uterus, and it basically leaves like a big wound or scar, whatever you want to call it. And that's going to bleed until it kind of scabs over and heals, right? So you might not have pushed a baby through your vagina. You might not have pushed for hours or whatever, have a tear. So you might not be bleeding that way, but you still have that placenta coming off of your uterus, and it's going to leave a spot there that is going to be bleeding. So like Kelsey said, it's a lot less bleeding, but it's still going to be there. And it does kind of throw people off. They don't expect it because they're like, well, I had a C-section. I shouldn't be bleeding. But yes, you do still bleed.
Yeah. And I give you the exact same education that I would give to somebody that's had a vaginal delivery too. You are watching your bleeding for clots bigger than a golf ball size. You don't want to fill up a pad in an hour. That's too much bleeding. And keeping your bladder empty, which we'll get into later in this episode. But that's all going to help with that bleeding.
Definitely.
In the same vicinity, we're looking at that incision. So during the OR, when they are closing you up, they're putting a dressing over that incision. At least at our facility. I think most facilities, you have some type of dressing on. Ours is called a Mepilex specifically. We are looking to make sure that it is not oozing. There's no drainage on it. If there is, we would have to talk to the doctor. There might be little spots, and that would be normal.
Yeah. So if you guys have a little bit of drainage that comes, and like the nurse notices it on your dressing, what we typically do is we circle it. We use like a little marker or a pen, and we'll circle it, and we kind of monitor it that way. And typically, most people don't have a lot. If you do have a lot, they might reinforce your dressing. They might change your dressing, but that dressing stays on for 24 hours. So it kind of just depends on your situation. If it seems like there is too much drainage coming from it, then they might take it off, assess the wound, look to see if anything is separated in your incision, or if it just has a spot that's kind of easily able to ooze. Other than that, they might just put something else over it. And some people have no drainage at all. So if you have a little bit, it is okay.
Yeah, exactly. Let's see, what else? So the medication that you got during surgery, we are going to be watching your oxygen levels. So you are going to have a pulse ox on your finger as well. That is going to stay on for 24 hours as well. So
just a little sticker.
Yep, there's this whole deal of 24 hours that we're bugging you for, but that is another one, and that is because anesthesia just is technically lasting in your body for that amount of time that we want to make sure that your oxygen levels are staying okay, watching your pulse as well.
The medication that we give in your spinal, typically, not everyone gets it, but typically you get what's called Duramorph, and it does last in your system for 24 hours. So when we are saying that we're watching this or doing things for 24 hours, that is why. It is in your system for that amount of time. So hopefully your first 24 hours will actually feel a little bit better than your second 24 because you have that additional Duramorph working in your favor. So let's talk about your pain medication then. So along with the Duramorph, there are some other things that we typically give you that are scheduled. So we are going to give you 4 doses of what is called Toradol. So I think we have talked about Toradol in another episode, but it is an IV form basically of ibuprofen. It's a similar type medication, but it can also be harsh on your kidneys. So we give you the 4 doses, and then after those 4 doses of IV Toradol, we switch you to oral Motrin. We also schedule everybody Tylenol around the clock, and we just bring that and give that to you. And then you are also given like as needed medication. So right away after delivery, we give stuff like Dilaudid or fentanyl or morphine. It kind of depends on if you have allergies or what your facility does, but we typically give Dilaudid. And then you will also get oral oxy. So once you're able to eat, that's the better option just because it lasts much longer. Dilaudid works really quick if it's in your IV, but it doesn't last super long. So once you're able to kind of eat and whatever, we will let you get that oxy, but you do have to ask for that one because we don't just hand it out. It's if your pain's not being covered by the things that we're already giving you. And then other things medication-wise that we're giving you is stool softeners. So we just talked about all these pain medications that you guys are getting, and you also just had a major surgery. So we are keeping you guys on top of stool softeners because we do not want you to be any more backed up than you are already going to be.
Yeah, so pain medications and surgery are ultimately going to slow everything down.
Yeah. Yep. And we will also be giving you IV fluids. So we give you them before. I know we talked about this in the previous episode. You have IV fluids going when you go back there. They give you fluids during surgery, and then we keep those fluids going until you're kind of able to eat and drink on your own. So speaking of that, I feel like that is a very common question. Actually, probably people are still in PACU when they ask the question.
Oh, absolutely. When can I eat?
When can I eat? You guys starved me. You didn't let me eat last night. I couldn't eat all morning. When can I eat?
Yeah, so I'm sure everybody says the exact same thing. I tell every patient the same thing. As much as you feel like you are starving, I want you to try something small right away. So again, you had major surgery. Your stomach's probably not going to tolerate a whole lot. So I will typically have somebody start out with like a Jell-O or some saltine crackers, graham crackers, some juice. If you feel okay after eating those, I will absolutely let you eat a little bit more.
Yeah.
But there are some people that take a bite or two and they feel miserable. So nausea is a huge thing after surgery. Yeah. So there is medication that we can give you for nausea as well. If you start throwing up, you're just going to kind of pull on that incision. So if we can avoid it, that's why I'm kind of a stickler on it.
Yeah.
And then as you progress throughout the day, you can eat more and more. I just always tell everybody if you start to feel icky while you're eating, just stop and try again in a couple of hours. And again, I would not go for anything heavy like a cheeseburger or spaghetti, something that's going to hurt coming back up. And those things are going to mess with your stomach and you are for sure going to throw up.
Yeah. And I have seen people think that they feel fine and they eat a meal and they're like, oh no, I need a bag. And it hurts to throw up.
Yeah.
Like you just had surgery and that like mechanism of your like Valsalva maneuver, you're engaging your muscles that just got cut into. It is really, really painful. So with that being said, it is difficult to do this while you are puking, but you cough after you have a C-section, you're kind of turning in bed, and even if you are puking, we always give our patients a pillow to support their incision. So if you do feel like you're going to puke, try to free up a hand and hold the bag with one hand, or hopefully there's somebody in the room, whether it's your nurse at the time or a significant other, and they can help hold. and put a pillow on your incision and push pressure towards your body. So you're kind of giving support to the incision so your whole like abdomen's not forcing outwards. It can just be really, really uncomfortable for patients when that happens.
Yeah, throwing up, coughing, sneezing, laughing.
Laughing,
None
yes.
of them are going to be your
That one
friends.
surprises people too. They're like, I know the sneezing hurts and the coughing, but like, I'm just giggling. Like, don't make me laugh. Don't be funny. Like, that's what they tell like their significant other or whoever.
Yep.
Don't make me laugh. It hurts so bad. So other things that are going on at this time. So, as you know, you are in bed. You're not getting up and moving right away because you just had surgery. We had you all nice and numb. So Kelsey kind of talked earlier about keeping your bladder empty. So you will have a Foley catheter put in right before the surgery, which we did talk about in the last episode, but that is going to stay in until you are able to be up and moving and can tolerate going to and from the bathroom multiple times. So we don't want your bladder to be too full. As we talked about, it can cause increased bleeding. So we do keep that in, and it's kind of a situational thing for people. It just depends on like what time of day you had your C-section. We obviously don't want a Foley in your bladder at an extended period of time if it's not needed. If you're up and moving, it should come out. But there are times, like Kelsey said, you're really nauseous or you're really painful and you're not able to get out of bed multiple times, and so it does stay in a little longer. If you have a scheduled C-section, typically when we take that Foley out is the next morning around 6 in the morning. So it's probably like 20-ish hours it's been in on average. Not always the scenario. Some people like them out the night before, and that's okay too.
Yeah. And again, you guys, if you're like, I need this Foley catheter out, you can always ask. Mm-hmm. I've definitely taken out sooner. Some people are like, oh, I don't have to get up and pee tonight. Let's do that
right,
one.
Exactly. And I know we have discussed Foleys in other episodes, but just as a reminder, in case you didn't listen to those ones, once a Foley is removed from your bladder, we are wanting you to pee within the next 6 to 8 hours. It would be at the very, very most. So I know we talked about that we do like peppermint. We can use peppermint if you're having a hard time peeing. We can use warm water and have you spray that on your peri area while you are trying to pee. We can bladder scan you, so we can take a little machine. We can check to see how much urine is in your bladder. So it looks kind of like an ultrasound wand. We just press it on your abdomen from the outside, and it gives us a pretty good estimation of how much urine's in your bladder. And if it's not too full, we can give you a little more time. If it is too full, there is a chance that we either put that Foley back in if you can't pee, or we're putting a straight catheter in. So what that is it's kind of similar to the Foley. You just take the tube, the catheter tube, you insert it into the bladder, drain the bladder, and then take it back out. And then we're back to square one. You get another 6 to 8 hours. So I feel like with the Foley catheter, you just want to make sure that you are waiting until you feel ready to get it to come out. Like, don't push it, because I've had that happen where like people just want it out. They want it out so bad. And I get that. It's uncomfortable. It's annoying. But wait until your body's ready, because you don't want to have to get it put back in, because it stinks.
I was 100% going to say that too, because there absolutely is somebody that is like, I'm ready to get out of bed. I'm ready to get this catheter out. I want to say I typically wait to closer to 12 hours to take it out.
Yeah.
And it's just because your body, again, had anesthesia and everything was numb, and your brain kind of has to just like correlate back to those body parts again, and be able to tell you that you have to pee and that you know how to pee. And,
right.
Yeah.
Like, are you awake, bladder? Do you know what you're doing?
Yeah. So I know I agree with everything you just said.
And another thing we're going to keep in place because you are in bed for a while is called SCDs. So what these are is they're pumps that go on the lower part of your leg, so around your calf and shin, and they squeeze from the bottom up. And what they are doing is they're helping circulate your blood so that you don't end up with a blood clot, which obviously is very, very important. We don't want anyone getting a blood clot from staying in bed. So even if you do get up once and then you're back in bed, I still keep them on my patients until they are frequently in and out of bed on their own.
Yep, I agree.
They get really sweaty. I do give people breaks. I feel like that's like the number one complaint.
I was just going to say that as well. I feel like people either love them or hate them.
Yeah.
The sweatiness is absolutely why people can't stand them.
Yeah.
I tell, if I've taken care of you before, you've heard this story, and I don't know if I've said this in another episode, but when my mom had surgery, she had to wear SEDs, and she came home and told me, she's like, it just felt like a bunch of minions were giving me a massage on my lower legs.
That is
like,
adorable.
Okay. All right, you liked them.
Yeah. Were you on pain meds at that time too, Mom? Or
That's a good question.
oh, goodness. So speaking of getting out of bed, right? So we're telling you all these things we're doing to you because you're not out of bed. So let's talk about getting out of bed for the first time. So I ideally like to get my patients up within the first 8 hours after surgery. And yes, that does seem quick, I think, to people. Like they're like, I just had surgery. I can't get out of bed. But if you think about it, you just had major abdominal surgery. You have a huge laceration across your abdomen. So your muscles are already going to start overcompensating to kind of protect that area. So when you lay in bed for an extended period of time, your muscles kind of stiffen and tighten. They're not loose. You're not moving them. You're literally just like holding them still. So what do your muscles do? They get used to like being straight and stiff and not moving. So then when you go to stand up, it's so much more uncomfortable. So I always try my best, and I encourage my patients to do this. Like, you need to find a balance between not overdoing it, but like getting yourself going and moving, and it's gonna hurt. It's gonna be uncomfortable. Nobody likes getting up after a C-section. Everyone, I feel like, says the same thing. It feels like it's pulling. It feels like it's tugging. Like, it is uncomfortable. So I ideally will have you kind of medicated. I go around your medication schedule, hopefully get you a little more comfortable. And then hopefully when you get out of bed, it's not horrible. And then I feel like it encourages the people the next time it's not as bad.
Yeah, 100%. So I will honestly try to warn my patients right off the bat too. Be like, hey, you will be getting up sooner than you think you are. But again, it is to benefit you, because the longer you wait, the more uncomfortable you're going to be.
Right.
Also, I feel like a lot of people say that it actually feels good to stand up and move once they're up. So
yeah, definitely.
That's another thing too to kind of like hope for. But once you're moving, it's the scariest thing to just get up the first time. And to go off of that, if you get up and you're sitting on the side of the bed, there's always going to be 2 nurses with you.
Yes, always.
If you don't feel good, we're not going to make you do much more.
No.
So we kind of go slowly if we can. But there is a lot of people out there that they're like, nope, let's go. And, you're walking into the bathroom the first time.
Yep. So there's definitely phases to that. So we can call it dangling. When you sit on the edge of the bed, it's called dangling. And that's what some people can do, and that's okay. And then some people are able to just stand up and they're like, this is too much, I don't think I can walk, and that's okay too. I've had patients literally pivot to a chair so we can clean up their bed and just get them new sheets and everything.
Yeah, and back to bed you go.
Everyone's a little different, but as soon as you are able to just take a few steps and like kind of loosen everything up and get yourself used to walking, the better I think it's going to go for you, and I think the better the pain is overall.
I agree. Do you think we can explain how to get out of bed without demonstrating?
Oh my gosh. I would like you to demonstrate it on the couch, Kelsey.
Not today.
So I think in my mind, there are 2 separate ways that somebody can get up, right? So the 2 ways that I see patients do it, we can kind of talk through. I'm going to start with one, which I encourage my patients to do this. So what I try to get my patients to do is kind of roll to a side, and then we're going to use the head of the bed, and we're going to start putting the head of the bed up while you are on your side, and we just go nice and slow, guys. So like, try to picture this going in slow motion, basically. Okay, so you kind of roll over onto your side and the head of the bed starts going up, and while that goes up, we will bring your legs from laying on the bed down towards the floor. So you kind of like sit up as the bed is sitting up. And I always remind my patients, use your legs and use your arms. Try as much as you can to not use your ab muscles. And I think everyone that has had a C-section before, you will understand this, because you don't realize how much you actually use your ab muscles until you like can't use them. And then all of a sudden you're like, oh my gosh, like you feel so awkward moving, just trying to focus on using your arms and legs. So I feel like that's kind of like the most common way in how I encourage my patients.
So ultimately, being able to go to your side, you can lift up on that arm that's on the bed then.
Yeah, you kind of just press yourself away from the bed and like sit the rest of the way up.
Yeah, see, it's hard not to like motion this.
I'm acted up for you guys. We'll take a separate video of Kelsey doing it. The other way, I do have some patients that like to do it this way, where they will just sit the head of their bed up first. So they're still normal in their bed. They sit all the way up, and then they just slowly scoot themselves and turn to the side. I find that way to seem harder, but some people, that's just what they want to do, and that's okay. Whatever feels better for you.
If it works for you, but I think you're definitely going to end up using more ab muscles than you think you are doing it that way.
I think so too, yeah. So either way, go slow. I always tell people go slow. And then once you get to the edge of the bed, you need to scoot your butt as far as you can towards the edge of the bed so that when you go to stand, you can use your arms and you can use your legs to give yourself that height to stand up, because you don't want to stand up literally just using your abs. It's going to hurt. It's not going to feel very good. So if that didn't make any sense, we apologize. And again, we'll take a video of Kelsey doing it for you if you guys want it. Okay. Other things I think that we just haven't really touched on yet. I do want to go back to pain meds because I kind of forgot to talk about this one. We more recently have started using lidocaine patches a lot, and I did forget to bring that up earlier. But I don't want to forget about it.
No, it's a good one. I've seen it probably in the last year or two. It's fairly new to our facility at least.
Yeah. Well, we're always a day late and a dollar short up in the Midwest, right? But I find them to be so helpful for our patients. So basically, you guys, it's this little sticker that we are going to put around your incision, not over it. And we can cut it and put it in multiple places or wherever you're feeling more pain. And it has lidocaine in it. It really, really helps with pain. So if you were not offered it, you should ask and see if it's an option for you.
Yeah, I've seen it work very well for people. And then aside from pain medications, using ice packs to your incision is going to be major too. And I think a lot of people are like, nope, that's not going to work. I think it does though. Ultimately, it takes down that swelling, that inflammation. I don't expect you to keep it on all day. Actually, you're not supposed to. You're supposed to take an hour or so break every once in a while from it. But I would encourage it. If patients, decline it, I'm a pusher for the ice pack. I will be honest.
Another thing you guys can do that is non-pain medication related for your pain is an abdominal binder. So some people already they get there and they already have heard of it. They have friends or it's not their first rodeo and they're like, I need an abdominal binder.
Yeah, I believe my friend brought her own.
See, yes, you definitely can bring your own. We do have them. But basically what it looks like is it's this big, I don't even know how you want to explain it. It looks like a big bandage almost that Velcros over your abdomen. So it's very firm kind of.
Kind of like a corset.
It is. It's like a corset.
But it's Velcro, not tying it tight.
Go. That is a really great way to explain it. And it just holds everything in. So you know how we were talking about the coughing and the sneezing and how you want to put pressure? It is doing that for you. So is it the most comfortable to probably lay in? No, but when you are up and walking, a lot of patients really, really like them.
Yeah, I agree. It kind of just holds everything up and in place. So you're
definitely
not dragging down.
And I know we talked earlier about what the dressing over the incision is going to look like. So let's talk about the incision itself, guys. So we know that dressing is going to stay on your incision for 24 hours or around that time. What does it look like afterwards? So I would say more often than not, around the incision is pretty bruised.
Yeah, absolutely.
It's definitely bruised.
Yep. Whether it's the edges or just the top of it or just the bottom. I wouldn't say the whole thing is ever bruised.
No, there's usually an area or definitely not all of it. You're right. But we are always monitoring for what an infection is going to look like. So the nurses are in charge of that. So we are looking for an increase in swelling. We're looking for redness. We're looking for foul drainage coming out of your incision. We don't expect to see any of this while you are in the hospital, but it can happen. I always encourage the support person to be looking at this. I want you to see what I am seeing. So I want you to see it normal. I want you to know what is not normal because you are in charge of that. This is so important. So looking at the incision and then monitoring for a fever afterwards is really, really important because we see people come back with post-op wound infections and it is unbelievably painful. So reiterating, we need to be watching this incision.
Yeah, so let's talk about things to prevent infection then. There is one thing that we can use called inner dry. So the main thing you're going to do is keep your incision dry. Mm-hmm. That is the number one. Moisture is going to create bacteria. That's going to create an infection.
Exactly.
So we have at our facility at least something called inner dry. It is like kind of a cloth.
Yeah.
That gets placed over the incision, in between a fold if you have one. And then it releases the moisture and it keeps it dry. So it kind of
basically like travels through the cloth.
Yeah. Gosh, I didn't think that'd be so hard to explain.
I know, right?
Yeah.
That's kind of what it does.
So anyways, we will definitely be giving you one of those. And over the next couple of weeks while your incision is healing, you can keep using it. You can rinse them out and reuse them. As long as they're dry.
Yeah, exactly. And if you feel like you need an extra or two, ask for that, because there is no reason why we don't want to give you extra of that to go home. Like it is very important. Yeah. Also making sure like after you're taking a shower, you are making sure to pat that incision very, very dry. Keep it dry.
Yeah. So you can shower. You can let the soap run over it. You obviously are not going to want to scrub it by any means, but soap can go over it and be rinsed off, and that's totally fine. As for baths, I would absolutely talk to your provider because they might have a preference. But if you are sitting in a tub, you are basically harboring bacteria into that area. So I would probably avoid it. I know that they're not going to let you go swimming, a pool, hot tub, anything like that until it's healed. But for a tub, I would say if you're soaking your incision, I wouldn't do it longer than, 15, 20 minutes.
Yeah, exactly. And then when are you guys going to go home? We kind of touched on this in the last episode, but most people are staying 2 to 4 days, 3 being the most typical amount of days. So what are we doing over these 3 days? Literally everything we just talked about, right? And on top of that, we are helping you with feeding. We're doing tests on the baby. We are monitoring you guys, and take our help. Okay, we will change the baby's diaper. You have a million to do. People are like, oh, you don't have to. And I'm like, I'm getting paid. I will change all of the diapers. Like, you're going to change diapers for the next, however many years. Like, let me change the diapers.
Yeah, make sure you just kind of get the education that you know how to do it.
Yeah.
And do your practice once or twice with us around. And then, let us take over.
So, take advantage of the nurses and take advantage of the help that you have. Especially if you're somebody that doesn't have family that lives right next to you or somebody that can support you. Because, again, you are healing from a big surgery. So it's a lot. So take the help.
Yes.
So we will have another episode. We're going to talk about some discharge stuff and things that you guys need to look for. I don't know if we're going to do a postpartum and vaginal all in one, or if we are going to separate them. We'll kind of see what kind of pans out here. But we will go a little more into depth with that stuff in another episode. I think we kind of talked your guys' ear off enough today. So as always, let us know if you have questions, if there's something that you specifically want to know about C-sections or C-section recovery. Let us know. We can always just message you back if that is the case. But we really appreciate you guys listening, and I hope you are back again next week.
Yeah, thank you.